We're here today with Professor Sir Colin Dollery. Colin has had a long and distinguished career in clinical pharmacology, starting off at the Hammersmith as Professor of Clinical Pharmacology and then more latterly at GSK. So Colin, thank you for seeing me today, and it would be great to talk about your career, work and achievements.
Well, I'd be very glad to do that. I think one of the things I have to say is that about the age of 17, I decided I wanted to be a doctor when I was going to a grammar school that didn't teach botany or zoology, but somehow I managed to get around that and progressed.
What made you decide to go into medicine?
That medicine looked so interesting. And I always wanted to be a doctor who was looking for the science of medicine rather than just being an excellent clinician. I wanted to be a clinician scientist even then when I was not sure how I was going to do it. And my father, who was a chemist who graduated in Oxford, he wanted me to go back to his St John's College in Oxford and read chemistry. And I had a sort of black night of the soul and said I wasn't going to do that. And I wanted to get into a medical school. So I had to leave the grammar school and go to the local technical college. And I had to spend 2 years then doing botany and zoology. In fact, for that exam, I took all 5. I did physics, chemistry, biology, botany and zoology.
Great.
And I got a very high mark at it. I wrote to 4 medical schools, the Birmingham Medical School, when they did offer me a place then, whereas the other 3 offered me places, but they would wanted me to go in the army for 2 years. And I thought, since I was 19 by that time, because I'd had 2 extra years, that really was a waste of time. But where did that black night of the soul come that I really wanted to do medicine? It just, something in my brain said it would be the most interesting thing to do.
And do you regret that?
Not a bit.
When did your interest in pharmacology start?
Well, at Birmingham, I had a house officer in surgery with the professor of surgery for 6 months, and then a house officer in medicine with Melville Arnott, who was the professor of medicine there. And at the end of that time, he said, well, what do you want to do now, Colin? And I said, I want to go to Hammersmith. He said, well, fortunately for you, Colin, I know John McMichael. Well, unfortunately, McMichael had already got the job for his SHO there, but Russell Fraser, who was in endocrinology, had me, and I did that. I did 6 months there, and then 6 months at the Brompton. And I actually had a scholarship from the MRC to go to Oxford to read pharmacology for a PhD. But about the 4th or 5th month of that time, the phone went on one of the wards, and it was John McMichael. And he said, I want you to come back to Hammersmith as my research registrar.
So why did you decide to go to Hammersmith from when you were in Birmingham? Was there something special about Hammersmith at the time?
Hammersmith was the best research centre in the country.
At that time?
Yeah. But John McMichael then basically said, I want you to get on well with your research. And I said, do you mind what I do? And he said, well, if you've got something interesting you want to do, you do it. I already knew a guy called John West, who was in the lower medical corridor, which was where most of the labs were. But both of us knew that the MRC had just finished building a cyclotron at Hammersmith, and it was only the second hospital in the world that had a cyclotron on the premises. And we knew that they were going to produce oxygen-15 and carbon-11. And for the next 2 years, we pumped papers out into the journals using this to measure ventilation and blood flow in the lung, both normal lungs and things like mitral stenosis. It's been known for a long time that in mitral stenosis, the lower part of the lung would show different changes on the X-ray, but we could show that the blood flow was lower in the lower part of the lung than up here, but a perfectly healthy, yes, normal person sitting here like this would be almost no flow at the apex because the gradient is about that much. So we got lots of fun things.
At the moment, there is a career track people have developed for academic clinical fellows, going into clinical training fellowships, lecturers and so on. But there probably wasn't a track like that when you were training and you had to develop your own track. Is that right?
Well, I think that if you seem to have good ideas to work on them, people would, generally speaking, support them. And you could get on with it at tremendous speed. You know, the thing that goes on in most British centres now is about half the speed that I went on at Hammersmith in those days. You know, most of the research registrars that I have known in recent times had to go off to a district hospital for a year or something like that, which was a complete waste of their time.
They do have to go through a lot of different mandatory training requirements. And at that time, there probably weren't so many mandatory requirements, but it didn't really make you a worse doctor than the doctors we get at the moment. And do you think that's one of the reasons that people have slowed down, because there's too much regulation going on?
Yes, that's my view. I mean, I was fortunate in the environment. It was just unbelievably exciting. And of course, it moved on, because the next thing that happened was I moved away from the cyclotron. So I picked up a journal in Circulation and found a short article in there written by a senior medical student in Indianapolis, saying that he had injected fluorescein into people and taken retinal pictures of their eyes. But he then went off and did something else. And I thought, you know, there's a lot more I can do there. And we had a tremendously exciting time looking at diabetic retinopathy and hypertensive retinopathy and leakage from arterioles in severe hypertension and so on. So we had a cascade of work going on there.
Okay. So different things coming in from the cyclotron, perfusion, scanning, and then going on to fluorescent imaging.
I mean, the one thing I think, I suppose, is that a lot of my interests were cardiovascular in that area, because what I then went on to do on a much longer scale was working on hypertension. I think one of the things that really clinically I'll never forget, I was called by a staff nurse on the ward who had just admitted a patient and said, "Dr. Dollery, come quickly. I think he's dying." And this guy was lying in bed with pink froth coming out of his mouth. I took his blood pressure, and his systolic pressure was 300 millimeters of mercury. So I sent the nurse down to run to the pharmacy. The only injectable drug they had was pentylinium tartrate. And I injected a pretty high dose. It's a ganglion blocker, as you well know, a pretty high dose. But nevertheless, after 10 minutes, the pink froth no longer came. And after about 20 minutes, he was able to say a few words to me. And I took his blood pressure then, and his systolic pressure was down to the range 150, 160 millimeters of mercury. I think that was the most striking thing I ever did in medicine, but it also showed how exciting it was to work with the medicines, which perhaps people under those circumstances who hadn't been thinking about them would have done something as automatic as that. But if it hadn't been done that way, almost certainly he would have been dead in an hour or so. I had the good fortune that a whole sequence of new drugs was coming out. Mm-hmm. And I, in the end, had, I think, the second largest hypertension clinic in the world. The other one was at the Cleveland Clinic at that time. And one got very good relationships with, say, with people like Jim Black, and also with Merck. And they didn't scatter their drugs around all over the place at that time. They might give it to 4 or 5 centers because they wanted to get good data.
Okay. So when did you become senior lecturer?
I can't remember, but I became a professor about the age of 32 or 33, something like that.
Which is a fantastic age to become professor, a very young age.
Mm.
And then did you spend from 32 till you left Hammersmith mostly working on hypertension, different aspects of hypertension?
To a considerable extent, yes. I mean, by that time I had got a large MRC grant, and we had Donald Davis, who was a biochemical pharmacologist, and we had between 30 and 50 people at different times. And for most of the time, you would roughly have about half non-clinical and half clinical people. And what we did is every week we met together, and then 2 of the people there had to make a presentation for half an hour. And it was that ability to keep the physicians and the scientists together that was really very important.
Over that time, what were your key discoveries, findings that you were really, really proud of?
Most of the ones have been things which have been shown to be going wrong. You know, when I've always been interested in drug safety, because I was working on alpha-methyl dopa. And one day, the chairman of hematology came up to me and said, "Colin, I want to take a lot of blood samples from your patients today in the hypertension clinic. And I said, why? And he said, I'll tell you tomorrow when I've looked at them. And quite a lot of those had got an antibody on their red cells. And some of them were hemolyzing. And we did a lot of work in trying to understand the mechanism involved in that. And I think that was probably the first time I really became very concerned about drug safety and also wanting to try and pursue it better than I had done in the past. And I've done that really up to now. I've had the good fortune, if you like, it's good fortune for the science, it's bad fortune for the patient concerned. But I kept with the cardiovascular ones and looked very much at the pharmacokinetics of the molecules and tried to relate them to the pharmacology. I wouldn't say that any one of those things was a breakthrough, but I think we were probably doing better work than most people on it. And certainly when I worked with Jim Black on a sequence of selective beta blockers, that was a very interesting era.
One of the things that you're very well known for is that you produced a lot of clinical pharmacologists in the UK who went off and became professors all over the country.
I know.
And so just give me sort of, an idea of how and why you decided to, really pursue that in that way, because, that I think that was the birth of clinical pharmacology, really, in a way, in the UK.
Well, I suppose the fact that I had the desire, but in fact didn't do it, to go to get a PhD in pharmacology in Oxford. The Oxford people were not altogether pleased with me or with John McMichael, but I have read very extensively. One of the things that I do is that I take a whole range of journals, about 10 which I actually pay for. And from that, you learn a great deal. Many of the people I talk to now are not physicians. They call themselves clinical pharmacologists. But basically, all they do with PK is measure the blood samples. And that's really silly, because in many of the drugs we're interested in, what we want to know is what cells they get into, whereabouts they get into them, what effect they will have when they get there. Now, that's more difficult to get that information, but it's not totally impossible to do so.
One of the issues that we're facing in this country at the moment is the numbers of clinical pharmacologists are going down. Why do you think that's happened?
Well, I think it's the way that the NHS has set about training people. My daughter is a cardiologist, and she's the deputy clinical director of the Radcliffe Infirmary in Oxford at the moment. But what she said, she knew how I'd gone along with my career. She said, by the time, Daddy, you were about to be appointed a professor, I was just finishing my period as a senior registrar. Because if you are going to be a research worker, you really need to be doing all the way through, I think. And that was the thing that I found so exciting, that more or less from the day I arrived at Hammersmith as a registrar, I continued to do research and encourage people to do research.
Many go and do clinical research and some go and do laboratory research, but very few people straddle the divide between laboratory and clinical research. But you seem to have done that in your career. Was there any particular reason you wanted to do that?
Well, I felt that you couldn't get to the depth of a problem if you were not going to have a very good appreciation and measurement of what's happening to somebody who had got a disease, or perhaps be a normal person, and at the same time having very good chemistry on what we could measure. And it gradually got better, of course, as time passed. But I don't see any wisdom in saying, well, I'm only going to do one of them or the other. If you want to be a clinical pharmacologist, you really have got to do both.
So in terms of, if you go back to clinical pharmacology, what do you think we need to do to be able to really try to turn around the specialty and make it more attractive?
I think it's become extremely difficult, Munir. Most of the people coming through in internal medicine want to go to one of the subdisciplines of internal medicine, in other words, respiratory, cardiovascular, neurology, and so on. They feel that they'll get more money doing that. We've got to persuade people that it's a really more interesting life than just to spend all your life threading catheters down the coronary artery or something.
So if I was a younger doctor, much younger, and was starting off my career, coming out of medical school, with an interest in going into clinical pharmacology, what advice would you give me?
Well, I think you've got to select an area of clinical medicine, I think. I mean, in principle, I've known some people who say they're going to general practice and to do clinical pharmacology that way. And I think that's quite an interesting idea. And I know one or two GPs who are very good, incidentally. But they can only do very unsophisticated measurements in general practice. And I think what I want to be able to do is to go to much greater depth. I mean, that's in a sense why I'm moving now beyond just an organ, but looking at the cells in organs. Because we're already beginning to realize that take a lobule of the liver. We already know that if you look at the cytochrome P450's distribution down a lobule, it's not the same. It goes towards the central vein. And there are lots of things in tissues where that happens. It was interesting in a sense that the people at the NPL were very excited when they knew I was going to try and do that kind of work, because they didn't think many people in the UK were trying to do it. And yet we do need to do that.
And clinical pharmacology has perhaps been the key specialty in UK medicine that has interacted with industry. Can you just give me your perspective why that is so important?
Well, because the new drugs always came out of the pharmaceutical companies, and it was really very desirable to learn as much as you could, not just the compound to come out and there's a box of pills and why don't you 50 milligrams in them and why don't you start doing some of your studies with that. I tried to go back to the companies concerned, and fortunately they were always quite willing I could go. And so Merck and Jim Black's various outfits were critical ones, because I would then spend several days probably with the pharmacologists and the chemists. And one of the things I liked to know was how the chemical molecules had been built and why particular ones were built but weren't quite as good, and so on. There was an awful lot of information there. So you then felt that you really knew exactly what you were doing. Now, of course, when you go to pharmacology in man, then you may get it wrong. We haven't talked about that so far, but I've seen one or two episodes of which I've certainly contributed some understanding of it. And that one of the reasons why now I'm so interested in being able to look at how compounds enter and concentrate in particular parts of cells, that in the future I think that may be something that people try and do routinely.
So you were at Hammersmith and then you were to work for GSK. Can you compare and contrast your work within an academic setting and then work in industry setting?
Well, of course, it was very different. I went to SB and I was there for 4 years. And the SB had an executive committee that ran SB, and I was a member of it. And basically, they had given me the role. They didn't call me a clinical pharmacologist, but they said that they wanted somebody who basically would straddle the late stages of pharmacology with a drug and the early stages, class 2 or 1A, and that I was a very useful person. And I enjoyed it tremendously because there were very good chemists at SB in those days, outstanding. And since I was very interested in the chemistry all the time, that was good. And I think actually if you're going to be a good pharmacologist, you do have to understand the chemistry of your molecules. And then, of course, we merged with Glaxo Wellcome. And I think it would be fair to say that the people from Glaxo Wellcome did not want Colin Dollery. And SB was absolutely determined that they were going to keep him.
And so if you were starting over again, would you choose to work as a clinical pharmacology industry, or would you choose to work in academia like you did and interact with industry?
Well, I think I enjoyed academia because of the clinical medicine. I'm a clinician.
Yeah.
I saw a lot of data on clinicians, and in fact, when something had gone wrong with one of the patients, that in clinical trials, there was often one of the people, they wanted me to look into all of the information with great care. And it was very interesting because sometimes it was just whether the dose was wrong or something of that kind. But other kinds, there was something happening in that patient which didn't seem to be happening in very many others, but it was never a serious reaction, trying to figure out exactly what was happening. Sometimes they were due to immune mechanisms, but sometimes it was very hard to work it out. But it wasn't quite the same as going to see the patients yourself. And I suppose that the reason why I so much enjoyed Hammersmith is I could go and see the patients myself. When the nurse said a new patient was coming in, I would get up and meet him at the door and shake his hands. I think there were simple things like that. You had to act as a human being with your patients.
In terms of the industry and academic interface, one of the things I think that may be important in the future is that we develop posts which are 50% academic, 50% industry, and have those kind of shared posts. And I don't know what your perspective is on that.
I think it can be done, and Merck have done it a bit. It's a bit more difficult than you might imagine, because are you going to be working on the same drug on each side of the phalanx, as it were? If you are, that's okay. And certainly when I was working on many of the drugs, when I was working with Jim Black, I would go up to Alderley Park, and we would discuss his pharmacology, and then he would want to know what I'd been doing in the way of measurements in man and so on. So that was fine. It was easier because by that time, in a sense, I think I was accepted as being reasonably sensible in the things that I did do, and perhaps sometimes quite exciting. To start at a very early stage with a drug company as half-time employer and clinical pharmacology unit could be okay. I just never did that.
If you were to pick particular individuals who really inspired you to do what you did, would you be able to name them?
I mean, there were loads of them is the answer. I mean, I was very, very fortunate in the people I work with. I mean, obviously, Melville Arnott in Birmingham, and very much, because John McMichael, I went to see him several times a week for what he wanted to discuss what I was doing. And he was, I mean, he was a tremendous engine in being really interested in what you were doing and suggestion about it. And he really felt that what I was doing, and to be fair, a number of other research registrars, but they were just registrars. I wasn't called a research registrar. I was a registrar. We're doing the same thing. And so we would get together. It just might be over lunch in a cafeteria or something like that, and be discussing what work had been done, say in endocrinology or something of that sort. I think we have to feel that we are part of a group, in a sense, that are together and are sharing ideas. Well, I remember the BPS for years and years, I mean, I was a very early member, and I felt that was very important because it was a way of hearing about a lot of pharmacology. You could hear a lot of different lectures, and that's why I go to the ASCPT as well, because you're the same.
Tell me what you're working on at the moment.
Well, this is the NPL. I'm working on the Orbitrap transferer. And Orbitrap is a very clever device for separating molecules. It took me some time to understand because they spiral, and as they spiral, you can sample them at their size. And one of the reasons I want deuterium-labeled molecules, it's somewhat easier to do that than with hydrogen and carbon molecules. We decided to do this with the glucocorticoid molecule because we knew that would home on the nucleus, which is what I felt would be, as an organelle, the best target. But I do also want to do it on mitochondria. And we haven't got the right agent for that at the moment. But I know that in a sense they exist, although you've got to be damn careful. I don't know whether you ever read about the phyluridine toxicity, which was 20 years ago now. But that was phyluridine, which was actually an antiviral for hepatitis B, would bind to HN1, the endonuclease transporter 1. But HN1 in humans, with an H in front of it, was actually bound to the mitochondrial membrane and slowly pumped the phyluridine across till it gradually prevented the ring chromosome in the mitochondria no longer functioning anymore. But I was wondering whether we could find something which would not be toxic, but which could be use that transporter. I think one would have to be very careful about it, obviously. We do get things into lysosomes. That's less easy because lysosomes are all over the place in cells, and so it's much more difficult to distinguish a clear structure. Just as I'm also interested in the endoplasmic reticulum. And I've been wondering about that too, but for the moment I've decided I will stick to the nucleus, the lysosomes, and possibly see whether we can do it in mitochondria. Because what I want to be able to do is to look at cells in different tissues and see how they vary. Because I'm sure they're going to vary a lot when we look at them.
If you were to look to the future, what's next for Colin Dollery?
One has to face it that one's intellectual capacity may be a little wilting as the time passes, so I'll just have to see. But at the moment, the NPL seem very keen to have me and seem to be enjoying it, so and I am, so all is well.
So if I was to ask you to give a lecture, 10 minutes, on what the future pharmacology is, what would be the key things that you would say?
I would have to think about chemistry. That is absolutely critical, because you need to know all of the properties of that molecule. I mean, one thing that really angers me is they talk about target engagement. And I said, it's absolutely bloody meaningless saying target engagement, really. You know, what are you talking about? Are you talking about the mathematics of it binding to a particular molecule and so on? Well, you better say, well, that's what you're doing. That's a really critical thing to do. If you don't know the chemistry of the molecules and the history perhaps of other closely related ones, I think it's very hard to do the pharmacology properly. But then, as you're now implying, we've got to do, just as we go for molecules, I think we've got to go for cells and to be able to do the studies on cells, which is considerably more difficult than doing the chemistry, I would say. But will, in principle, in the future, enable us to get down to exactly what we're trying to do with new molecules and what old molecules are doing. I mean, corticosteroids are an absolutely splendid example. I mean, I have an inflammatory skin condition, which is an autoimmune condition, fortunately not too severe. But if you put a layer of clobetasol on your skin, first of all, it stings. And the changes begin within literally 30 seconds, a couple of minutes, you know, in capillaries not being so dilated and so on. Nobody actually knows to this day exactly how that's being done. And actually, one of the reasons why I'm quite keen to do these studies on the monocytes is to look at the speed that things get in. And once we know that they're getting in, to start thinking about whether we can persuade John Stamm, and I don't know whether we will be able to, is to look at what's happening when you do that. Because John Stamm's machinery is a very clever machine. So you take monocytes, 100 ml, you come through, you've got pure monocytes. You then, if still at 4 degrees centigrade, he's looking at nuclei, so he breaks the cell envelope. And then, having got all the nuclei, they break the nuclear envelope, still at 4 degrees centigrade, and then they put it into the mass spec. But this is a very complicated mass spec. And at the far end, they get the material for the whole, not just the protein coding region. But the problem is the massive information you get at the far end.
Yes.
But in principle, once you've got that, you can see exactly what's happening in the cell.
So we are already in the era of big data.
Yeah.
And do you think clinical pharmacology should become much more engaged with big data in its wider sense?
I think it's inevitable that we become engaged in it, although I think also we will want to have people who are very intense mathematicians who can look at it, because looking at big data is not something really you just sort of sit down with a calculator or a PC at your desk. You've got to have very sophisticated procedures. Because biology is the big challenge of big data. One of the things I've always pointed out to people is you should not ignore advances in technology and instrumentation, because often that enables you to solve a problem which otherwise you could not have done.
So I'm certainly not a technologist, but I know how to use them to be able to answer the questions I want to.
I'm probably a bit more of a technologist than you are. You know, I built my own computers. And
Did you? Fantastic. Well, I'm not a technologist, but I know how to use technologies. I'm an early adopter.
Oh, of course, I'm a radio ham, and I have been since I was about 8, I think. I built a crystal radio, and then I built a 2-valve radio, and then eventually I decided I was going to build a transmitter, so I got a radio license. And at that time, after the war, I was able, with my pocket money, to buy a very nice receiver from an aircraft, a BC-342. At that time, there was no television signal in Lincoln.
Right.
But then a television station was started in Birmingham, and Lincoln was on a hill. And it was my father asked if I could produce a TV set. So I got a cathode ray tube set and built it to get a TV signal. But then he wanted to sit there watching the cricket matches on this sort of 5-inch green screen. And it was impossible for me to transmit, because even if I transmitted when he wasn't there, everybody's TV set for about 200 yards in every direction was blocked. And so I had to give up at that point.
Well, thank you very much, Colin, for seeing me today and telling me about the fascinating career that you've had. It's been an absolute pleasure to talk to you today. Thank you.